Does that answer your question?
Yeah.
It's like all or none with the lights in this room. So goals for today, movement analysis to start off with. So warm-up activity, keep you sharp. And then chapter 4. And then we have a chapter 4 activity to see how well you know the muscles. And then we get into chapter 5. And then we have some questions about a specific condition for the shoulder called GIRD, G-I-R-D, glenohumeral internal rotation deficit. So those things. So let's go ahead and just let you take off on the brand new movement analysis. Hi. Okay, sure.
Yeah. This is what I got hung on the text. Oh, good.
So please work together.
I'm like, yeah. I need to go look at what I got.
So just like always, there's combination of eccentric, concentric. That's the first question. Is the weight going up or is the weight coming down? Sagittal plane, front to back, frontal plane, side to side.
Body weight can count as the weight.
Yes.
Yeah. Sure.
What is that, a walleye, Corey?
What?
Walleye?
I can't remember.
That's an awesome shirt. Yep, lifting. Opposition to gravity.
Some of your questions are the same.
My brain can't work.
This is the one where it's opposite. So in this area, the shoulder is flexed, whereas this one is opposite, right? That's it, right?
Yes, but I don't know if it's flexion. It might be abduction or adduction.
The scapula and
Would it be
scapulae.
horizontal abduction? That's right. So I'm like, this would be like, but it's because then I'm like, I think it's this way.
So rotates this way.
Yeah.
Awesome. So I hope you're getting adduction for the first one. ADD, adduction.
Would it be horizontal or would it just be regular adduction?
Regular adduction, just pulling into the side.
How is it
Would they have a downward rotation too?
Scapular would. So out here to the side, remember? So all we're talking about is upper arm, humerus, shoulder movement. So side to side, abduction, adduction.
If it was here going out, it would be ab.
So if you're going from here back, it would be ab.
Okay.
Yep, so remember page one, page one of your movement and muscles handout, if you're adducting at the shoulder, then you can just go across the column. And you can say, so adducting of the shoulder is going to be downward rotation at the scapula. Very, very important. You've got to be able to use the information going away from the anatomical position, what actually happens in practice. The third one that you'll see is quite interesting. I'd be interested to know if anyone's ever tried that, the third one. I used to do those a lot. So let's look side to side. You should have frontal. There's a pull-up, underplaning sagittal axis.
The shoulder, I'm like, okay, yeah, that's fine.
We would use the extension muscles.
The bicep.
No, see where the big
Pull this
Oh, lifting it off.
Spider curl.
So you say move the next one?
Not that I don't know.
I only know that because.
That's a spider curl.
I did that once.
Those are try.
Why do they call them spider curls?
I don't know. They work. This is.
Yeah. Yes. So they know we're doing whole muscles, we're doing whole body. Yeah.
How are you, Billy?
Good.
You get eccentric on that one?
Yep.
Good, good. How are you, Aspen?
Pretty good.
How are you, Connell?
Not too bad.
Very good. Yes, good.
Yay.
How's it going over here? Yeah. Yeah, so try as much as you can. So Ty mentioned a good point. Try not to use your movement and muscle handouts. You're like just cementing these in your brain.
We're not there.
Have you cemented them in the brain yet?
I can do these, I can't do them all.
Would you want to study it together sometime?
Yeah, see how it goes.
Find a way to work it. I'll call it second work.
Just a little. Okay, so. Where is it?
Good.
Wait, I'm lifting. Wow, I thought he was holding a bar.
At the end of the semester, it's gonna be automatic.
Yeah, it's hard to see that. So it'll still be selection, but it'll
Hey,
actually.
we meet this weekend.
Good one.
Are you tapering now or still in doing volume?
Still doing volume. 12 mile workout.
Yes.
7 miles a month.
We're not looking for
Yeah.
2459 yet.
Hmm.
That's all conference.
Is conference here?
Regionals.
Okay, okay.
Yeah.
Is it the same course as this weekend?
Other than it'll be
Oh, okay. Cool. Take a few more minutes, finish it up. Seems like everybody's on track.
Oh, that's.
We're getting back to that. We're doing the easy ones first. Or easier.
Yeah, so, I mean, you go from here.
Okay, I guess that's.
If it's one,
Yeah, you can do that.
if it's like, this is lifting, which is concentric, it's all gonna be, yes, all gonna be.
Because I mean, like, if we think the shoulder joint will technically be function.
Yeah.
So if the shoulder's technically like supporting this. Oh, really? Right, but then if we look at shoulder, like, so the shoulder joint. Oh, really is when you put. Oh, I'll try. Injury or just.
Getting through it. Guys, all
Well, I
done?
mean, it's on his end, I would,
Okay.
I mean, it's gonna elevate up if it's.
That's the way, yeah.
So would the knees go from
Would be.
flexion to extension?
Mm-hmm. And it's not, it doesn't have to be a lot, it's just some.
It's just that,
well, I know that the final movement
isn't this, you have to lift that above, right? Or is
Yes,
it a?
but you're just doing phase one.
Okay.
How's it going? Coming together?
I think so, at least in my head it is. Do both rhomboids help in elevation?
Bilateral. Minor and major.
Extension.
I don't know if you came up with all these names.
I know if I did, I would say, well, if you're excited, right?
Yes. Finishing up?
Yeah.
Dan, how are you? Starting to recognize groups of muscles and that's the goal. It's like everybody's finished, you're on the last one, so we'll give you about 30 seconds and then we'll pull back together. What's your goal time for this weekend, Aspen? Have you broke 20 yet?
I broke into 20 for the 3 mile, but not like an official 5K. I haven't.
Okay.
So probably just a break into 20.
Oh, cool. Good.
Yeah, because I ran a 20, 40, I want to say, for a 3 mile. So hopefully I can.
Is Amen the fast course?
It is, but I hate
Is it kind of boring?
Yes.
You're just kind of going around.
Yeah, I'm
Well,
like
it's nice for
across country.
spectators
It
because
is.
you can just see your athlete several times.
It is. And like, see, I'm very much like a true cross country course. Like, I'd rather be going over hills,
Just
over
out
water
in the middle of
crossings.
nowhere and then come back.
Exactly.
So you see them
So,
at the
like,
start and finish.
Yes.
The Montana Marathon.
Unless you have binoculars.
You can't see them. Yeah, no, I'm like, that's very much how I like to run.
Okay. All right, gang. Let's pull back together. All right. So we have some different ones on there. So first one, adduction. So we're talking out to the side. So frontal plane, adduction. What muscles adduct the shoulder joint?
Pec major,
Mm-hmm.
upper lower,
Yep. What else?
lat.
Big adductor. The adductor is probably the strongest emphasis in that, obviously. So just because there's 4 muscles listed doesn't necessarily mean they all have equal contribution. So there can be portions of a muscle or parts of a muscle, like the pec major is in there but not strong. But the lats, obviously the teres major is a big part of that. So do you have any questions on that one? Elbow flexion, pretty straightforward. You're lifting your body weight and so on, so it's concentric. Okay, so the next one, so a decline tricep extension, but we're starting with the concentric or the eccentric phase. Yeah, the eccentric phase, so it's being lowered, so the joint action is not extension, it's flexion, even though it's the triceps that is controlling flexion of the shoulder joint. So that'd be sagittal plane, arms are tucked in front to back, sagittal plane frontal axis. Okay, so the next one is really unique. It's a elbow flexor movement. The emphasis here is more on the long head of the bicep. So there's really two parts of the biceps. The long head is more lateral, short head is more medial, because the long head has effects at the shoulder joint. If you do elbow flexion with the shoulder joints in flexion, then you're going to be emphasizing that part a little bit more. So it's interesting what electromyography can tell you in terms of which part of a muscle is most involved with the movement. So the lay term for this one would be the spider curl. I love the lay terms more than the official terms. They're a lot more interesting. So it's concentric, so the plates are going up, just regular elbow flexion, sagittal plane frontal axis. And then we have a nice power type move, phase 1 of a power clean on the back. So we're going from the hang position into a shrug position just before we initiate the second pull. So everything is going to be extending with the scapula elevating. So you got your scapular elevation, everything on down concentric. So you can't have concentric and eccentric on the same analysis. So all the muscles are contributing to lift, and then all the muscles would contribute to lower. So they're all lifting, imparting momentum and acceleration into the bar and so on. So hip extension, knee extension. What's our word for extension of the ankle joint? Plantar flexion. I don't know why that is, but that's an exception where we're actually extending, but it's plantar flexion. So everything in the sagittal plane except the shoulder girdle elevation, which is what plane? That would actually be the frontal plane. Scapular elevation is the frontal plane sagittal axis. So as if you're looking at someone from a anterior view, and you only have the sagittal view there, so it's just something you have to commit to memory on that one.
So you said the shoulder girdle is the frontal plane?
Mm-hmm. So the reason we refer to shoulder girdle and scapula as the same thing is because most of the movement, as we've studied chapter 4, takes place at the scapula. So there's compensatory type movement of the sternoclavicular and acromioclavicular, but most of it is just with the scapula and the rib cage. So any questions? Okay, all right, so keep that. That's part 1. So as I was reviewing material for this chapter, I came across this study. This is from a Canadian journal. This is posted in your PowerPoint folder, Physiotherapy Canada. And so you can see the title of this study, really interesting, Diagnostic Value of Acromiohumeral Distance. Acromiohumeral distance, so we're talking about the undersurface of the acromion. Do you remember how many types of acromion we have? From the discussion. So there's 3. Okay, so 3 different shapes of acromion, which affects how much space you have between the undersurface and the top of the humerus, especially the supraspinatus tendon, which is the problem with rotator cuff impingement. So acromiohumeral distance, so underneath the acromion to the top of the humerus, in rotator cuff pathology, implications for advanced practice physiotherapists. So we have very little space under there. So in most people, it's about 10 millimeters. So this study in particular looked at distances less than that and correlated it with rotator cuff pathology. So the beauty of an abstract is that you can get the summary without having to look for it in the article. So acromiohumeral distance less than 6 millimeters was reliably measured in plain radiographs and was strongly associated with important clinical and imaging features of advanced rotator cuff pathology. So this may assist with clinical decision-making by allowing judicious use of more costly investigations and referrals for surgery. So let me show you some pictures here so you can see. So you recognize these structures in here that we've seen with chapter 4. So we're looking at the acromion right here and the lateral clavicle right here and then the top of the humerus. So in this case, that's pretty good space. So that's greater than 6 that was associated with the rotator cuff pathology. Just another view down here. This would be another good prognosis with 9.47 millimeters. So with rotator cuff pathology comes certain symptoms, obviously pain, dysfunction, inability to lift your arm, to abduct or flex beyond 90 degrees, because in order to go beyond 90 degrees of abduction or 90 degrees of flexion, what has to happen with the scapula? You know, it has to rotate, right? It has to move, elevate, rotate. So that's why we have that scapulohumeral rhythm where we have corresponding actions of the shoulder joint and shoulder girdle. Again, mostly the scapula. So can you see the difference? So imagine a lot of you going PT, PA, all of these great professions, and you'll be sitting in your own practice examining this type of situation. So you can see the atrophy here, so moderate atrophic changes of the supraspinatus muscle, okay, so that's going to be on top here, and severe atrophic changes of the infraspinatus. So that's going to be right down here where this arrow is, on a patient's right side observed on clinical examination. So all kinds of things. If you can't use something, what happens? It degenerates, right? So this is very important. So you can see probably still pretty functional on this side. So you can see the muscle is more developed there. Probably not expressing symptoms here, but you can see definite changes over here where there's probably some issues there. So I included that under your folder. And let's go ahead and get into the rest of chapter 4. So how many muscles do we have for the shoulder girdle? 5. Now, the rest of the story, there's technically 6, but the 6th one doesn't do very much. It's kind of a joint stabilizer. It's called the subclavius. So it stabilizes the sternoclavicular joint. So really when we're talking about prime movers, big, large muscles that are involved with stabilization or movement of the scapula, it's 5. So posterolaterally, we have the serratus anterior. So that's involved with abduction and upward rotation. So very important. We talked about the winging of the scapula. So very important to strengthen that muscle through different closed chain functional activities. So what does that mean? Closed chain versus open chain. So we talked about this briefly in lab with our squats. So closed chain means the distal segment is fixed. So the feet are fixed or the hands are fixed. So to strengthen the serratus, we'd want to do something with the hands in a fixed position, at least a lot of the time. So weight-bearing type position. So we talked about the application of just simple exercises like that, where you're in more of an upper extremity weight-bearing type position that requires abduction or protraction of the scapula. Okay, so anterior muscles. Okay, so we're looking at the pectoralis minor, which is also involved with abduction. So your two primary protractors or abductors, the serratus anterior as well as the pec minor. So the pec minor running right here in these 3 fascicles. So a fascicle is just a bundle of muscle cells. The pec minor also participates with the rhomboids in downward rotation. So the scapula has to be initially in an upwardly rotated position for the rhomboids and pec minor to contribute to pulling it back down to that anatomical position, as well as depression. So really, the only exercise I can think of that does involve depression, you remember what it is? Because anatomical position, you're already in depression. So there's now, okay, so elevation is the shrug. So what are we doing when, okay, so parallel bar dips, right? You're gonna be in a weight-bearing position where you actively have to depress the scapula right at the end of the movement. Okay, so here's the subclavius. So the mysterious subclavius. So it's right here. See just that little tiny band of tissue there, little muscle tissue that stabilizes the sternoclavicular joint. So it does participate in depression, but we don't consider it much of a prime mover. There's actually a muscle, it's kind of similar on the back of the elbow, that's called the anconeus, that stabilizes the elbow joint, but it doesn't participate much in extension of the elbow like the triceps. Okay, so posterior, we've got the trapezius. So 3 different segments, different nerve branches, different fiber alignments and attachment points. So upper fibers along with the rhomboids contribute to elevation. So shoulder shrugs, and then with the movement we had today during the first pull of a power clean, definitely imparting momentum through scapular elevation. But also something we may not think about is extension of the head. So if the origin is fixed, then the muscle would pull the head back because the upper fibers attach all the way up here to the base of the skull. So getting down here to the middle fibers, these fibers work strongly with the rhomboids for adduction. So retraction, so just really pulling those shoulder blades in towards the spine. Middle fibers also upward rotation as we studied yesterday. Lower fibers, so interesting, lower fibers work with the pec minor in depression. So you think, okay, so the end of the parallel bar dip if you really want to emphasize pec minor and lower trapezius, you want to make sure you're pushing your shoulders, actively pushing your shoulders down before you initiate that next repetition. Okay, rhomboids, so they are deep to the middle fibers of the trapezius. So again, adductors based on that horizontal type alignment. So you've got the major and minor. Minor is up here, major down here, so a little bit smaller there, implied in the name. They are upward a little bit, so you get some elevation there as well.
Where does the pectoralis minor insert?
Has its insertion on the ribs 3 through 5. So we're going to go through each of the muscles individually now in just a moment. So levator, scapula, you can kind of see it right here. There's so many layers of muscles on the posterior side. We get to a lot of those layers in chapter 11 on the trunk. Okay, so once you take out a pencil, you're not turning this in, but you need to know this information because this class is all about bones, muscles, and nerves. So now we're going to go over neural innervation for each of these muscles. So 5 muscles, technically 6. Okay, so this is basically just flat out memorization. So there's always a part of anatomy where you just have to commit to memory. So this is that part. Okay, so trapezius. Let's start there. So cranial nerve 11. So there are 12 pairs of cranial nerves. Cranial nerve 11 just happens to have innervation for the trapezius. So innervation means the connection to the nervous system. So the trapezius is the accessory nerve right here. So you can see kind of in that darker, not sure what you'd call it. It's not pink like these little branches, but it's thicker and darker. That's the accessory nerve innervating the trapezius. So the trapezius also has some innervation from branches of C3 and C4. So what am I talking about when I say C3 and C4? What vertebrae? Yeah, so the 3rd cervical, the 4th cervical, and why do we name peripheral nerves based on vertebrae? Refers to what? Yeah, so where they exit, the vertebral foramen on each side of the spinal column. So we have 31 pairs of spinal nerves. So branches of C3 and C4, in addition to the accessory, would innervate the trapezius. So I ask you on an exam, or I just say, okay, trapezius, and then a line, I say, okay, tell me. What's the innervation? Say accessory, and then branches of C3 and C4. That's the answer. Okay, so everybody good on that one? Okay, so that's really the only, well, I won't say only, but the primary muscle that has innervation from the cervical plexus. So these plexuses are aggregations of nerves. So the official definition is here, are proximal segments of peripheral nerves. Proximal segments means close to the spine or away from the spine? Close, yeah, close to the center, the core of the body. So emerging from the foramina, what's a foramina? It's a hole. Yeah, that's how the nerves get out from the spinal cord. Of the vertebral column with intertwining nerves that form individual nerves distally. Why would we have this intertwining going on? What happens if one of those branches is damaged? Then we have another nerve that is going to make up for it, right? So nerves have a really poor regenerative ability. So with this intertwining, we have multiple branches that could potentially serve a given muscle. So that's the reason. So with the exception of the trapezius, which cervical plexus, okay, so accessory branches of C3, C4, most of the other shoulder girdle muscles are innervated by the brachial plexus. So let's take a look. Brachial plexus. Okay, so 2 muscles, levator scapula and rhomboids. So those muscles are innervated by the dorsal scapular nerve. Dorsal scapular nerve, right here which comes from C5. So it's a branch off of this nerve root here. This is the nerve root. So in this color, the roots, C5, C6, C7, C8, T1. What does T1 stand for? What? Thoracic. Okay, so C5 through T1, those are the roots. See all the way down. So this dorsal scapular nerve is a branch from C5. So two muscles, rhomboids and levator scapula. Those two. Comes from C5. You'll want to remember though, dorsal scapular. That's what I want you to remember. Dorsal scapular nerve innervates the rhomboids and levator scapula. Okay, subclavian, what muscle do you think? Guess. Subclavian nerve innervates the subclavius muscle. Subclavian nerve, subclavius muscle. So that's it on that one. Okay, so long thoracic nerve. So this comes all the way, can you see? Follow it up and see if you can identify where it comes from. What's its nerve root? C5, yeah, so that innervates the serratus anterior. Serratus anterior with two R's. Serratus anterior innervate is innervated by the long thoracic nerve. So that's a good name because it looks like it is pretty long, coming down there to innervate and branch into the fibers of the serratus anterior. Okay, so very last one, the medial pectoral nerve. Medial pectoral nerve innervates the pectoralis minor. And that's it. So can you memorize those? It's not too difficult. So those are the nerves for the muscles of the shoulder girdle. That's all you need to know.
So we don't need to know, like, we need to know the names, not the branch, like C5 branch.
Just the names. Absolutely. So
5 nerves.
So you've got dorsal scapular, levator scapular rhomboids, you've got subclavian, subclavius, medial pectoral, pectoralis minor, long thoracic, serratus anterior. What's the trapezius? Accessory, which is not a spinal nerve. What type of nerve is it? It's a cranial nerve. Is right. What else with trapezius? Branches of C3 and C4. All right.
So it's all the muscles that are underlined in red. They're the
So
nerve
those are nerve branches.
branches.
Yep. Okay, so any questions on that? Any clarification needed on that? About what's expected, what you'll be asked?
So know the nerves and the muscles they.
You need to know the nerve and the muscle. Okay, trapezius. So muscles have two different attachment points, most of them. Some muscles connect to each other, but most have a couple attachment points to the skeleton, origin and insertion. So which is more stable, the origin or the insertion? Origin. So it's typically what happens is a muscle moves from the insertion towards the direction of the origin. You can tell what a muscle does by looking at fiber alignment from the insertion to the origin. So in terms of origin, we have attachments to the axial skeleton. So we're looking at the base of the skull. So you can see noted in red there, then the 7th cervical vertebrae, the spinous process of the 7th cervical vertebrae, and then all the way down through the 12th thoracic vertebrae. So the spinous processes of the last cervical and then all the way through the thoracic. That's the site of origin. That's the stable part. So the insertion is out here on the spine of the scapula as well as the lateral portion of the clavicle. So you can see shaded right here, these parts that would represent the insertion. Insertion. So what are the expectations here? So if I gave you a picture of this, would you be able to identify, knowing about the general idea of an origin, general idea of an insertion, would you be able to point to which marks are part of the origin, which marks are part of the insertion? So axial skeleton. What's the axial skeleton? What is it?
Brain and spinal cord.
Okay, so the skull, the vertebral column, and the rib cage. That's the axial skeleton. What's the other part of the skeleton? What's the other 126 bones? The appendicular skeleton. Okay, so why is it the appendicular has so many more bones versus the axial? You got hands, right, and feet. So you got 27 bones in each hand, 26 bones in each foot. So that's 106 bones right there. So we only have 80 bones in the axial skeleton. So you see the origin is part of the axial. So skull and then vertebrae. Okay, so if it's a scapular muscle, it's going to have its insertion somewhere on the shoulder girdle. What two parts of the shoulder girdle are there? Clavicle and scapula. So that's where the insertion is going to be, because that's the part that's actually going to move. So when we talk about elevation, depression, upward rotation, downward rotation, protraction, retraction, those are all things that are happening here at the shoulder girdle. So that's where all your insertion sites are going to be for shoulder girdle muscles, somewhere on the clavicle or the scapula. So the site of origin is going to be over here on the more stable axial skeleton somewhere. Okay, so levator scapula. Levator scapula. So site of origin, what's it going to be? It's going to be on the axial somewhere. It's going to be on the transverse processes of the first four cervical vertebrae. You can see right here, little dots right here. You can see, of course, you can see it right there. It's O, which means origin, but could you recognize that? Because it's the axial. So because it's a scapular muscle, the insertion has to be somewhere on the shoulder girdle. So it's right here on the superior angle of the scapula. So based on the name there, it levitates, it elevates the scapula. It also has a few other weak functions. Okay, so rhomboids, can you identify the origin? Yeah, somewhere on the axial skeleton, right here. So it says right here, spinous processes, the 7th cervical, first 5 thoracic. So it looks a lot like the middle trapezius. Middle trapezius is kind of more horizontal, whereas this is kind of angled upward a little bit. So the insertion point has got to be somewhere on the shoulder girdle, because that's what moves. So you're going to have the medial border of the scapula here. So elevation, adduction or retraction, downward rotation, all of these movements here would be part of rhomboids. So Courtney asked a good question. You would just lump the function of the minor, which is on top, and the major underneath. They would be similar. Okay, so serratus anterior. So the site of origin, somewhere on the axial skeleton, right? So it's going to be the top surface of the first 9 ribs. Remember, rib cage, that's part of the axial skeleton. So that's where the origin has to be. Surfaces of the upper 9 ribs, side of the chest. So the insertion point has to be somewhere on the shoulder girdle, because that's what actually moves. So it's going to tuck between the anterior surface of the scapula and posterior rib cage and have its insertion here kind of on the underside of the medial border of the scapula. So it's hard to picture, but it's slipping underneath between the scapula and rib cage to insert on the medial side. So abduction, protraction, along with pec minor, as well as upward rotation. This muscle is so important to avoid rotator cuff impingement. So being able to engage that muscle to get the scapula to rotate properly. Very important. So Chinese weightlifters, the best weightlifters in the world are from China, and they have very well developed. Can you see the serratus right here? Look at that face. So the serratus right there, you can see, because they spend a lot of time with that scapula in that upwardly rotated position, because they have to be able to stabilize that weight overhead. So they're putting a weight, a lot of times twice their body weight over their head. And then what do you have to do? You have to dive underneath it into, is that a deep squat? Yeah. So he would probably get a good score on the deep squat analysis, right? So awesome. Okay, so pec minor, very similar to rhomboids and serratus anterior in its functions. So it has its site of origin, again, somewhere on the axial skeleton, so it's got to be ribs 3 through 5, and then site of insertion there on the coracoid process. So on the scapula, where the part that's going to move is where the insertion is going to be. So the functions there, upward abduction, protraction, downward rotation, works with the rhomboids for that role. And depression. So remember dip with the lower trapezius, pec minor. So after a while you start to put these things together in groups in your mind. Okay, so subclavius. So this is a muscle, mostly a role in the sternoclavicular joint stability and protection. So it's just right here. So it has its origin again, axial skeleton, right here at the junction between the costal cartilage of the first rib, and then slips just underneath the inferior portion of the scapula, or the clavicle for its insertion point there. So really not a mover so much as just it's tensed to stabilize that segment. Okay, so the overall summary, chapter 4, overall summary, here we go. So scapula abduction, agonist, can you identify from the picture? So if I put this on an exam with pictures, could you tell which muscle? Okay, so what's this? Pec minor, okay. Yeah, okay, so those are your two agonists for abduction or protraction. Okay. Scapula adduction, what part of the trapezius? What is most emphasized? Yeah, middle, we could maybe say lower is in there, maybe the upper part of the lower, if that makes any sense. And then what's this right here? Minor and major? Yeah, rhomboids, right. Okay, upward rotation, again. I think earlier in chapter 4 we talked about how all parts of the trapezius contribute in some way. So in pulling on the scapula in different ways to create this upward rotation effect. Of course, serratus anterior. So middle and lower may be involved more so than the upper, but those are the primary ones for upward rotation. Okay, downward rotation, can you identify? Pec minor and rhomboids, yeah, good. Okay, elevation, levator, probably upper and middle trapezius, middle to a much lesser extent, rhomboids, so 4. Okay, depression, which part of the trapezius? Lower, good, so pull straight down, probably just these fascicles right here, so fascicles, bundle of fibers, probably more these fibers versus these fibers in here, and then pec minor. Okay, all right, so next activity, so we're on to part 3 for today. So I want to see how well you know your muscles. So we're going to do this for about 10 minutes, bring it back together, and then we're going to start chapter 5. So work together, time to get out your books. This is all about muscles. So we'll give you a start. So one across is lower trapezius. One across lower trapezius. Three down is middle trapezius. So that should give you a good jump start. Three down is middle trapezius. One across is lower trapezius. Yes. Yes, good. You're getting it. So you have the R for two down, right? So hint, hint. You can do it. There you go.
I know, I might have to double check that. I'm like sitting there counting, I'm like, wait a minute, this sounds like the same one.
So that great big one all the way down the middle, eight down, serratus anterior. Serratus anterior. Two R's.
Are you doing a push-up?
Then 16 across, you should have a good clue on that one. If you put serratus anterior in 8 down, you should have a pretty good clue on what 16 across is.
For 12 days, it's only the same day.
Yes, good. Anybody remember that? The depression, scapular depression? Yeah, 3 letters. There you go. EIP. Okay. So 20 across and 16 across are the same muscle? Or the same segment of the muscle? So what's 19 down gotta be? Yeah,
Never even thought of it.
right.
What did you say?
What was that?
19 down's gotta be shrub. 5
I was
letters.
just looking at
Yep, yep, he said it was.
Yeah, 20 and 16, the same muscle segment. Starts with a U. Good. So 22 is another part of the trapezius, not the upper. Starts with an M. I'll give you help on 17 down. It's a lat pull. 17 down is a lat pull.
I have a quick question. So I know that this one starts with lower, but I'm kind of,
Let's see, so what is that?
it's saying distal attachment, triangular space, base of scapular spine. So I'm trying to figure out exactly like what part they're talking about. Is it saying like the angle of the scap, or just lower
That's
scapular?
a muscle, it'd be a muscle.
Distal attachment. Oh,
That'd
so
be
it's
the
saying it's
insertion.
distal.
That's the insertion, triangular space, basically.
Oh, it's saying that's what its insertion is, not what is the, okay. So the
Have to be part of the trapezius, I think.
lower trapezius then?
Let's see, so,
Is it,
8 down would have to be serratus, so that'd give you an E.
yeah, and then that's rhomboids with an O, so I'm assuming it's lower, so the word must be.
Yeah, it's gotta be lower trapezius, does it fit? Looks like it might.
Yes, yeah.
It does? Okay, so 11 across is lower trapezius. Thank you, Shay.
there's
So,
two frontals.
two
I
frontals,
think.
14 down would have to be frontals.
Yeah, there's two frontals.
14 down would have to be frontals.
Because upper's gonna be.
And
I do
10
not know, but I
across
just figured out, I think
would also be frontals.
nine down is letter stuff.
You doing, Brian? Okay. So 7 across is bench press. So 21 across has to be what? Originates upper 9 ribs. Yes, serratus anterior, right?
Thank you. I was like, I've heard 17, and I was like, there's no 17.
And then trying across will be those three.
That's the only one I've had the entire time. Perfect.
Nine down.
Good, Tyler, you're right. So Tyler's right, 9 down, levator scapula. Let me just right here.
Well, it's 60. Because
Origin C1 through C4, that would have to be, levator as well. So I'm sure, is the scapula in there, or just the levator part?
oh shoot, I was going all the way down.
It's 6 down, or is 6 down? Levator scapula. That's, yeah, that's C1 through C4. Yeah, just the A.
I know that has to be, but it doesn't fit.
Yeah, so sometimes the scapula is just with an A and not with the E at the end. So both of the levator scapula ones, 6 down, 9 down, are both just with the A and without the E at the end. 6 down, 9 down, levator scapula. Well done. Great. Well done. Awesome. So it seems like everybody's finishing up. Give you about a minute here to. So just intended to help you just kind of think about muscles.
Are we trying to sit?
Nope, everybody's here today, so I can just remember. All done? Good, close. So, if you haven't got yet, 22 across, middle trapezius. Middle trapezius, 22 across.
There's a good reference to go to, like, looking for this page. Chapter.
Well done, Jackie. Good. How are you guys? Finishing up?
I'm just trying to understand.
Okay, so call out. What are we missing? Let's help each other get finished. Haley, what do you need?
I'm done.
Okay, great. 6.
Yes.
What is it? 6. 6 down. I think we said that was levator scapula with the A, not the E. 6 and 9 down, I think we said was levator scapula. Okay, ready to move on to chapter 5? 11 across. What do we get for that one, everybody?
Lower trapezius.
Lower trapezius. Thank you. Okay, all right, so I'm just gonna, you can, if you're still not quite done yet, you can kind of work on it or work on it after class. This is just kind of intended, just another way of getting these muscles in your mind and getting those actions and origins and insertions and so on. Okay, so shoulder joint. So this book is really good at this logical progression, going from proximal to distal. So we go chapter 4, shoulder girdle, chapter 5, shoulder joint, chapter 6, elbow, radial ulnar, chapter 7 is the wrist and hand, and then the second half of the book we go through lower extremity and trunk. So, all right, so the shoulder joint, as we've already studied since day 1, scapula moves in conjunction with the shoulder. So humeral flexion and abduction, there are corresponding actions at the scapula. So elevation, upward rotation, and abduction. Humeral extension and adduction, corresponding actions at the scapula. So in teaching this class for several years, there was a need to have just one concise document, which is why I created the movement and muscle sheet, so you wouldn't have to constantly be going back to your book. So you have everything just in one nice location for all the chapters together. Internal rotation, horizontal adduction, okay, so scapula abduction, protraction, and then exactly the opposite for external rotation and abduction of the humerus. So these things don't change. So scapulohumeral rhythm. So wide range of movement at the shoulder. It has a relatively shallow socket. So we have a lot of mobility, but what's the price of increased mobility?
Stability.
Yeah, stability. So there's that relationship there. So that's a key point. So rotator cuff impingement, subluxations and dislocations. So what's a subluxation?
It doesn't dislocate all the way.
Yes, good, Shelby, that's right. So it's a partial dislocation. So this would be a dislocation. Most dislocations are anterior with the shoulder in an abducted position. This would be an example of rotator cuff impingement. The muscle that's involved with that, the tendon of the supraspinatus. So due to its approximation to the acromion, excuse me, just underneath, so this is the acromion process, you have the supraspinatus muscle that runs just underneath that and attaches here to the lesser tubercle of the humerus, and so you have this impingement which causes this inflammation to take place. So the rotator cuff consists of 4 muscles. So it's the tendons that make up the cuff. So the rotator cuff provides dynamic stability to the humeral head. So what's the difference between dynamic versus static stability? Dynamic versus static stability. Or just, okay, so dynamic versus static, what's the difference? Yes, so static is like Brian said, not moving. Dynamic is moving. So we have muscular support to keep the humeral head in correct proximity to the glenoid when the shoulder joint is moving. So we have one muscle on the anterior side, the subscapularis, and then we have 2 muscles on the posterior side, the infraspinatus and teres minor. Okay, so infraspinatus on top, teres minor underneath, and then the supraspinatus on top. So you can see the proximity here of the tendon to the undersurface of the acromion. So if I gave you this view from your textbook on the next exam and asked you to label it, would you be able to do that? Hint, hint. So mark that. Okay, rotator cuff muscles involved a lot. You think of how many athletes, volleyball players, baseball players, constantly stressing their shoulder. Rotator cuff fatigue resistance is really, really important. So we have this inherent stability through the action of the rotator cuff, and then we have these larger muscles on top that are the accelerators. So we have the stabilizers underneath that are close to the shoulder joint, and then these large deltoid and pec major and so on top that are the accelerators of the arm. So these two groups, the stabilizers and the accelerators, have to work together. So you can't have weak stabilizers and then really strong accelerators. That's not going to work. That's an injured shoulder waiting to happen. So we have to make sure that the stabilizers are strong and then worry about the accelerators. So failure of the rotator cuff to dynamically stabilize can result in rotator cuff impingement syndrome. So just some more views of the rotator cuff here from the superior view. Again, the infraspinatus is on top. Teres minor we can see kind of peeking around the side there. Supraspinatus just underneath the acromion, then subscapularis is right here. So from the top view, the supraspinatus is a lot more visible. So again, make sure you're familiar with this picture. So supraspinatus, it's responsible for the first 30 degrees of shoulder abduction. That's another good test question. So we say shoulder joint abduction, it's got to be the deltoid, so we can do some EMG, and it's usually the middle deltoid is the strongest in abduction. But that first little bit, that first 30 degrees, initiating abduction is the supraspinatus. So you've got to have rotation of the scapula to go beyond 90 degrees up to full abduction. The infraspinatus is an external rotator. So it's the superior one on the posterior side. So right here. Teres minor is inferior to the infraspinatus. It's also an external rotator. So do you remember the three-way shoulder exercise that we showed through video? So we're doing this, and then what do? We do this, and then what? And this, and then the reverse. So the external rotation part is the infraspinatus and the teres minor. So those are your external rotators. Subscapularis, so that's the anterior part. So we can see the anterior part here with the rib cage removed, and that's an internal rotator. So that would work with the pectoralis major and the lats internally rotating the shoulder. Okay, so bony landmarks. So what if I put this on the next exam? Should be able to label it with a word bank. So scapular landmark, supraspinous fossa. So provides the origin for what muscle do you think? Supraspinatus. So the muscles that act on the shoulder joint have their origin on the scapula, clavicle, and proximal humerus. That provides the site of origin. So the site of origin for the supraspinatus is on the scapula. So supraspinous fossa right here. Supraspinous fossa. So infraspinous fossa, what muscle? Yeah, infraspinatus. So that's the site of origin. Infraspinatus, right? Infraspinous fossa right here, this broad surface. The upper part mostly, because then you have the teres minor down here that has its origin. So those muscles then have their insertion on the proximal humerus to affect the shoulder joint. So spine of the scapula, okay, so right here, terminating in the acromion, glenoid cavity, okay, glenoid fossa, relatively shallow, articulates with the humeral head. Coracoid process, okay, so anterior view right here. So two muscles, short head of the bicep femoris, as well as the coracobrachialis, have their origin there. And then acromion process, okay, here, so went over the three different shapes to that, and then inferior angle is here. Okay, so overall there are 4 key ligaments at the shoulder. 4 key ligaments. So these are the primary ligaments. I'm not saying those are the only ligaments. I'm just saying there are 4 that are key at the shoulder. So I want you to memorize these. So these 4 key ligaments. There are others, but these are the 4 primary ones. So the glenohumeral ligament, which actually has 3 different parts. The glenohumeral ligament forms the capsule of the shoulder joint. So that's what diarthrodial joints are characterized by having this, we call it a synovial capsule. So in the case of the shoulder, the capsule is made up of these 3 ligaments. So you have this superior, middle, and inferior glenohumeral ligament. So that's one. That's the first of the 4, glenohumeral ligaments. So this makes up the capsule. So this is underneath all the muscle making up the shoulder joint capsule. So these aren't muscles. It's kind of, the illustration is a little bit poor. It makes it look like muscles, but it's actually the capsule for the shoulder joint. Okay, so second key ligament of the shoulder, the coracohumeral ligament. So can you tell based on the name the structures that are connected? So it's the humerus and the coracoid process. Yeah, so ligaments are named according to the structures they connect. Okay, so next one is the coracoacromial ligament. Coracoacromial ligament. So acromion process connected to the coracoid process. So that's 3. So glenohumeral, remember 3 segments, shoulder joint capsule, coracohumeral, right here, coracoacromial, right here. The very last one, so the last of the 4 key ligaments, going to be the coracoclavicular. So connecting the lateral clavicle with the coracoid process. So this one also has 2 parts. So trapezoid and conoid. So you want to remember these 4, the 4 major ligaments of the shoulder: glenohumeral, coracohumeral, coracoacromial, and coracoclavicular. So notice they all have that same prefix except for the glenohumeral. So you can just remember clavicle, acromion process, and then humerus. And coraco is the prefix. Okay, so bones. So the insertion point for muscles of the shoulder has to be the proximal humerus. So we have a total of 9 muscles that affect the shoulder joint. So these muscles have no effect on the scapula. They're just specific to the shoulder. So we have a total of 9. 4 of them are the part of the rotator cuff. So we only have an additional 5 to memorize after that. So these are the insertion points. So points of origin, somewhere on the shoulder girdle, clavicle, scapula. Points of insertion, somewhere proximal humerus. So the head, greater tubercle is a little more lateral. So you can see this prominence, a little more lateral. Lesser tubercle, a little more medial. So remember we talked about in lab how the teres major and latissimus dorsi have their insertion on this lip of the lesser tubercle. So we'll see how all that mixes in with the pec major, because the pec major kind of goes over the top and has this insertion over here on the greater tubercle. Intertubercular groove. What does inter anything mean? Inter. So it's inside or maybe between something. So inter, between the tubercles. So between the greater and lesser tubercle we have this intertubercular groove, sometimes called the bicipital groove. So what muscle do you think is associated with that? Yeah, bicep brachii. Long head of the bicep brachii actually passes up through this intertubercular groove and attaches inside the shoulder joint capsule. So that's very important because a lot of athletes, if they have, say, a labral tear, it'll also affect the long head of the bicep femoris, or bicep brachii as well. So we'll talk about that. And then deltoid tuberosity is this prominence about a third of the way down the diaphyses of the humerus right here. So that's the insertion for all 3 parts of the deltoid. Okay, so this is just a picture up here showing the relationship and how the long head of the biceps has this tendon that follows this bicipital groove up through here, and it actually attaches to the supraglenoid tubercle. So at the very top of the glenoid fossa is where we have this attachment of the long tendon of the long part of the bicep muscle. So the short head has its origin over here at the coracoid process. And then we can see underneath, just slipping underneath there, we can see the coracobrachialis muscle. So the coracoid process has two prominent muscles that are attached to it, short head of the biceps femoris and then coracobrachialis. But I also want you to notice that as we get down distally, the two heads of the biceps converge and have their combined insertion here at the radial tuberosity. So below the elbow joint and below the proximal radial ulnar joint. So what actions do we have at the radial ulnar joints? Yeah, supination and pronation. So I want you to just put your hand on your bicep. Okay, so we can do that, and then we can flex our elbow. So you get a pretty good contraction there, right? But what happens, feel the difference in contraction if you go from here and then just really turn your hand out just a little bit to get that maximal supination. You see that extra contraction? You notice it as you go into that extra supination? So what's the application then? You want to get a good bicep workout. You know, the dumbbells are good because what can you do with a dumbbell that you can't do with a straight bar? You can get that maximal supination, which activates that bicep even more. So supination is really important for biceps training. Okay, so multi-axial ball and socket joint. So all three planes, large freedom of movement, but we sacrifice a lot of stability. It's classified as anarthrodial. So where else do we have anarthrodial? Yeah, at the hip. How are we doing on time?
It's 1:30.
1:30, okay. All right, let's go a little more. Let's go a little more. Okay, so glenoid labrum. The glenoid labrum, this cartilaginous ring that surrounds the rim of the glenoid fossa. So here, if we were to take a cross section and peer inside the shoulder joint capsule, so we can see the labrum right here. So this is this cartilaginous ring that surrounds the glenoid fossa. So as you're looking at this picture, can you pick out the rotator cuff tendons that are outside the capsule? So again, the capsule is made up of the glenohumeral ligaments. So we have the superior glenohumeral ligament, the middle glenohumeral ligament, inferior glenohumeral ligament. So those are the capsular ligaments. But then on the outside we can, so supraspinatus right here, that's that tendon. So you have this subdeltoid bursa. So can you imagine if your rotator cuff or your scapula isn't rotating properly, you're going to slam that bursa right up underneath that acromion. So that's not good. So we have to have that, we can't have that scapular dysfunction if we want to have healthy shoulders. So infraspinatus tendon, remember it's above the teres minor. So teres minor is right here, and then the subscapularis tendon is right here. So just kind of, there's the coracohumeral ligament right there. So that was one of the key ligaments. So the reason we have the labrum is because it deepens that socket just a little bit, more than it would be otherwise, so we get a little bit more stability. So here we get into labral tear. So can you see this cartilage ring and how it's torn here in the close proximity of the long biceps tendon up here? So very stressful overhead throwing type activities that place a lot of stress and force through this area. So very important to have fatigue resistant muscles. So we're doing all those little tiny exercises. Remember we talked about Y's and I's and T's and W's and all of that to describe different patterns at the shoulder. where we can engage the scapula and shoulder joint at the same time. And we're just doing the weight of our arms or just little tiny weights for high repetitions. We're trying to develop that fatigue resistance so we can take a lot of the stress off of these passive tissues. So this is what we mean by a SLAP tear. So SLAP stands for superior labrum anterior and posterior. So the anterior and posterior part is right here. So the tear happens in the front and back of the attachment. What attachment? It's the attachment of this bicep tendon that comes up right through that bicipital groove and attaches right on top here to the glenoid labrum. So a lot of times you may have damage here to the long bicep tendon as well. So that's quite a healing process. Takes several weeks to rehab it and get back into where you can do those forceful throwing type activities. Okay, so this is probably a pretty good place to stop. Is there any questions? So great day today, 10 points for participation. We'll get back into chapter 5 on Monday. Thank you.
Nope.